So, briefly, I would like to highlight what is the objectives of this training program, standard treatment guidelines training program. So, have you ever attended any standard treatment guidelines training program?
Sir, in Jammu and Kashmir, we have conducted a standard treatment guideline training on. In Jammu and Kashmir, sir, we have conducted this whole module which you have published.
Okay.
Standard treatment guidelines for 200 medical officers. Ayurveda.
Okay, this is for the musculoskeletal disorders.
No. That the whole one.
Whole document. Okay, so whole document means that prepared by the state government?
No, it is standard treatment guidelines by, it is published by Ministry of Ayush itself.
Okay, 22 disease conditions already published by the Ministry of Ayush in 2000, I think 16, 17 like that. Yes. So actually, I would like to say, because I just spoken to you in the inaugural session, that what is the fundamental difference between the standard treatment guidelines already published by the Ministry of Ayush in 2016 and now what we are coming up actually. This is the first set of standard treatment guidelines that is for the musculoskeletal disorders. When the ministry has taken up this preparation of the standard treatment guidelines, particularly they have categorized the disease conditions and 22 disease conditions ranging from musculoskeletal disorders, some even metabolic disorders, and even some of the NCDs they have taken care, then obesity they have taken. So in this way, varyingly they have taken 22 disease conditions which are at that time said to be reported in the Ayush hospitals and dispensaries. So after reaching to this Directorate General of Health Services, it was thought that actually there is a need of very comprehensive guidelines in terms of, so for example, we say that what is the clinical relevance of that disease condition, how much patients, the incidence rate, what is the incidence rate, particularly in the Ayush system, how, what are our strength, and then what are the differential diagnosis, which is generally we often either neglect or often we not consider many of the detailed differential diagnosis of the disease conditions. Then even the referral criteria. Generally, referral criteria, we mean that, for example, we have categorized the entire healthcare facilities into 3 tiers. So you can just see in your standard treatment guidelines actually the first level of facilities, generally we call it as Ayush dispensaries or Ayushman Arogya Mandir Ayush. Now that terminology ministry is using that for the health and wellness centers. Then second level will be anything like that 10 to 30 bedded hospitals where the clinical specialities will be there, only single 2 doctor clinical speciality may be there, either Panchakarma, Kaya Chikitsa, like that. So it is limited. So that is generally considered as the second level of clinical establishments. Third one is actually whatever you are teaching hospitals, that multiple specialities will be there. For example, Shalyatantra will be there, Shalakya will be there, because many of these conditions are required to be mutually referred also. Then only the comprehensive, as you know that most of the musculoskeletal disorders are generally chronic actually in nature, and it runs for a long duration. So continuous follow-up is the most important aspect of these treatment, whether it is you take the osteoarthritis, whether you take adhesive capsulitis or even cervical spondylosis, lumbar spondylosis. There may be the treatment regime runs for a longer duration, even though the active medication may be limited to say 1 month or 2 months, 3 months, but after that the follow-up medications will continue for a long term, and even lifestyle modification also required to be followed up for a longer duration. So in a public health system, that is a challenge actually, because the patients often, how to follow for a longer duration is generally a challenge actually. Most of the patients need not be reported again to the doctor for a longer duration. So for that purpose actually we have to devise certain very clear-cut guidelines, and even the standard treatment guidelines itself, we have to say that at what duration the patients are advised to come back to the physician, and along with the follow-up screening, what should be the criteria for the follow-up screening. So based on that, we have actually devised this standard treatment guidelines, and also we have included the ICD classification. You may be knowing that ICD classification were generally adopted for the modern medicine actually way back, even for the ICD classification 9, 10 and 11 it is there actually, and even 12 is also partially implemented in many of the countries actually. But we from the Ministry of Ayush and WHO has a collaboration to develop the ICD classification 11 as a chapter, separate chapter, chapter 2. So in that Ayurveda, Siddha and Unani disease conditions have been categorized. So what is the importance of ICD classification? Generally our physicians may not be knowing actually. We gradually, the government of India thinks that every patient should have a separate, a clear-cut identity number. That is, one is what you call Abha ID. So whether in your states, whether the Abha ID has been implemented, many of the states it is there actually, but it may not be uniform. For Ayush, everything is implemented, Abha ID?
Yes.
No. So we will come with you shortly to implement the Abha ID for the Ayush patients also. So once it is implemented, the patient identity will be there. Second one, the interoperability. For example, if you are actually referring the patients to other systems of medicines or even higher centers, that continuity, you can easily understand where the patient goes and what is the actually the connection between different healthcare institutions, that you can easily understand. That is one. Second one is, by adopting the ICD classification, the same diagnosis, provisional diagnosis, whatever you are actually providing to the patients in the ICD classification, the same will be continued over a period of time for a different clinical setting. So that is also one of the advantages. At least there won't be much ambiguity. There won't be much ambiguity in terms of the diagnosis of the disease conditions. Even the modern medicine doctors also can easily understand whatever terminology you are using in the Ayurveda, Siddha, Unani, that they can easily understand that ICD class based on that ICD classification. Second one, what we have adopted is actually red flag signs. Generally, in the every system of medicine, there are certain red flag signs by which we should not, either we should consult with our either the higher hospital facilities, high super specialists, even modern consultants to manage that kind of conditions. Altogether we can refer such cases to them. So provided we have limited resources, we have limited clinical acumen, limited what you call the clinical material to deal such cases. So based on that, in all these 6 conditions, we have enumerated red flag signs. That red flag signs, it is not uniformly we have enumerated like that. There was a consultative process in identifying these red flag signs, in which the experts from Lady Hardinge Medical College and experts from Ram Manohar Lohia Hospital, they were part of that in identifying the red flag signs. So we mentioned them actually. These are our strength actually. And these are the areas where we are generally facing challenges. And these are the places, for example, in the lower level functionaries, only limited resources are available. One doctor may be there, certain medicines may be there, one pharmacist may be there. Beyond that, nothing is available. So there, which are the disease conditions which are required to be taken up that care, that also we have to very clearly understand. So all these factors have been included in these standard treatment guidelines. So begin with what is a standard treatment guideline. Generally there is you may be knowing that very clearly. It is a systematically developed in the sense there is a peer review process is there actually. For example, there is a national steering committee will be there, consisting of different experts. India is a vast country, so naturally there should be members from different regions. So we have initially constituted a national steering committee to deliberate upon what is a standard treatment guideline for musculoskeletal disorders. Then that outlined appropriate steps to diagnose, manage specific health conditions, and not only manage and even for the mitigation and even for the rehabilitation. That is also part of that actually. And in that very specifically, we have considered individual system-wise specific strength in dealing with such conditions. Then what is its importance in healthcare? It is a play a critical role in standardizing healthcare delivery, particularly in the complex resource limited environments. As I told earlier, in the rural area, wherever the healthcare facilities are there for Ayush, Ayurveda, ya Unani, ya Siddha, ya homeopathy, whatever it may be, the resources are very limited. Even the essential drug list, whatever published by the Ministry of Ayush, we say that around 100 drugs are required to be available. And the continuous availability and replenishment, these are even now also issues. You may be knowing better. In your states also it is like that. Many a time जब दवाई आता है 2-3 महीने के लिए दवाई आता है, वो उस टाइम सभी कुछ होता है, उसके बाद वो एग्जॉस्ट हो जाता है, देन सालों तक कई स्टेट्स में हमने देखा है सालों तक मेडिसिन आते ही नहीं एक्चुअली. सो दैट सिस्टम, until and unless that system is actually consciously developed by appropriate what you call administrative and technical decisions, actually that issue has to be thought about. That is why we are saying that even in STG also we have tried to define there are certain medication within that essential drug list, but options are there. Suppose one medicine is not available, then alternatively which of the medicines which can use simultaneously for that particular condition, that kind of options. So this knowledge is very essential for the field level practitioners. Then consistency and standardization, that is also important, because clinical decisions at a time, we understand that most of the practitioners in the field over a time of period of 5.5 years का जो इनका जो education के बाद या even postgraduate education के बाद आता है, their decisions, clinical decisions में just many of the standard formulations that mentioned in the classical textbooks, which is appears to be in the essential drug list, often neglected, and their importance is so much higher than the simply writing the what I say one popular proprietary medicines. So that we want to reignite our all the practitioners in the country. In the particularly in the public health में हमको हमारा essential drug list का importance काफ़ी है actually. So all the classical medicine which is actually enlisted in the essential drug list has to be clearly provided to the patients as per the condition. Patient safety is also important. How much period we should follow one particular type of treatment, that is also important. Whether it is Amavastha, Pachimanavastha, Pakvavastha, based on that the clinical decisions whatever you are taking, whether you are writing for 1 week, whether you are writing the patient for 15 days, Nirama Lakshana, how much time you are expecting. So all these are very important in making the clinical decision. So based on that the patient safety, simultaneous concomitant usage of modern medicine, that is also a challenge actually. Many a time long term usage of NSAID या स्टीरॉइड्स काफ़ी हमारा जो आप जानते हैं ऑस्टियोआर्थराइटिस वगैरह में इतनी पेन किलर्स हम करने के बाद आपके पास आते हैं. सो एट दैट टाइम whether the concomitant use of Ayurveda medications will be useful, whether its effect will be limited, all these things you have to think about that. So that is why we are saying that for systematic approach we should adopt our clinical principles and the patient safety also. Resource optimization, obviously already I mentioned, evidence based practices, ultimately this will lead to generation of the evidence base. Why we want to adopt STG? Generally DG has already mentioned whether it is a traditional medicine, whether it is a modern medicine, the patient is is a single entity. You cannot bind them along with only a model standard treatment guidelines. In spite of that, we are actually making these standard treatment guidelines. Why? Because there is a need of developing certain standards, developing certain evidence in traditional medicine through which we can make appropriate dialogue between modern medicine. Ultimately, we intend to bring these STGs, even the AIMS also, All India Institute of Medical Science, where the proposed Ayush integration is going to make Ayush academic departments in the AIMS. So whenever it is materialized, there also we will introduce these kind of standard treatment guidelines. That is one. Then can it lead to better patient outcomes? Obviously, because when you follow a very systematic approach to the patient clinical medicine, in the ground setting, obviously the outcome also will be more. So, from this training program, we specifically familiarize the participants with STG structure and components, how to apply the STGs in clinical practice effectively in the succeeding session. Actually, we have assigned these sessions in such a way that next session will be on specifically to the National Ayush Mission program. So, I hope most of you in one manner or other manner already assigned the role of National Ayush Mission also in the states, isn't it? Anybody who are not knowing about National Ayush Mission is there? Yes, everybody knows. So that means you may also know that there is a public health program under National Ayush Mission, which is called as National Ayush Public Health Program on osteoarthritis and other musculoskeletal disorders. So many of the state government has availed the financial assistance from the Ministry of Ayush. So this STG will strengthen the cause for that implementation in the field of that program also, musculoskeletal disorders. That session will be there, followed by this session. Then the modern medicine from the Ram Manohar Lohia Hospital, he will be coming. He was part of preparation of this STG. He will be coming you, orienting you on the what are the possible modern medicine understanding on these disease conditions and the differential diagnosis and the diagnostic criteria adopted and the red flag signs. It will be taught by him. Then it is followed by in the 2 sessions with the 3 disease condition from the national level experts. They will be orienting you the remaining thing. Then the skills, the necessary skills, and encourage the adherence to the standard treatment guideline. So evolving this STGs will be useful for, as I mentioned in the inaugural brief also, insurance sector. This is highly relevant because you may be knowing that as Secretary already pointed out that the Insurance Regulatory Development Authority already asked to strengthen the Ayush insurance sector, whereby the physicians, whereby the Ayush treatment, whatever availed by patients are actually able to get the reimbursements actually. So there, these type of standard treatment guideline, they are actually more and more requiring. So developing these STGs will ultimately make the cause for them. Then integrated healthcare, already I mentioned, reduce the healthcare burden, timely referral, that is also very important, limit the side effects, and digital health and technology. Ultimately, by implementing these things, actually later stage we can bring into some kind of digital technology device, a mobile lab like that, because for the ease of usage, because the time is very important. Generally in a clinical medicines, up to 15 to 20 minutes the patient examination should be happened with all the history and other illness, and it is a continuous process. In a single visit of the patient, it may not be possible to understand, elicit everything, particularly in the context of Ayurveda, wherever multiple variables are there, whether it in terms of Prakriti, Sattva, Kala, all these things are there. So in order to assess it and simultaneously to understand the parallel understanding in modern diagnosis and other things, it may be a challenging, and however we have to deal with the patient in a limited time also. So 15 to 20 minutes clinical examination may be enough for that purpose in the initial setting. Later it can be further, it will be strengthened in the next visit or subsequent visit. Then digital health and technology, already I mentioned. So where we are actually setting these guidelines, obviously at a 3 level. I told that in the primary level, whether it is Ayush dispensaries, 36,848, which is generally under the state governments, and even the central government also have the various kind of healthcare institution, whether in the ESI corporations, the CGHS, and other Ministry of Coal like that. So almost this much of level dispensaries are there in the country. So there, primarily the practitioners are to be benefited by these standard treatment guidelines. Similarly, the Ayush hospitals, more than 3,844 under the state and UTs, and in addition to that, Ministry of Ayush already supported integrated Ayush hospital at various states, and almost 33 integrated Ayush hospitals are reported to be functional. So there, the highest relevance is to such hospitals, because even though some manpower we have deployed in this hospital, some manpower is there, and how to have a system there actually. patient the reporting and very thorough, rigorous, systematic clinical examination and treatments, panchakarma or physiotherapy or yoga, whatever it may be, how to appropriately do these therapies and finally make a referral. There should be certain guidelines. So there these guidelines will be more beneficial because initially to set up these kind of institutions are a challenge, no doubt actually. So once it is streamlined, there won't be much problem. Already you have adopted certain guidelines that will be useful. But for even for the initial setting up of such integrated Ayush hospital, these standard treatment guidelines will be beneficial. Then Ayushman Arogya Mandir 12,500. There the CHO's role is very huge actually. We expect that they are supposed to deliver everything. Musculoskeletal disorders and other public health program, even community outreach, yoga, everything he will be coordinating. But then there should be standard guidelines also. And even the public health program what the Ministry of National Ayush Mission is implementing, that is also important. Even in co-located facility, this is an avenue. Since if we say that the Ministry of Health and Family Welfare and the Ayush Vertical and Ministry of Ayush jointly made this standard treatment guidelines, there the physicians at the co-located facilities will get more value. At least we can say that if we are following these type of STGs, then definitely there will be much value and there may be chances that deliberate cross-referral system can be developed. Then existing gaps already mentioned, there was no streamlining of Ayush practices, then inability to generate scientific evidence, reduce the health cost of the reduction, then ICD classification already I mentioned, then National Ayush Mission which is also very important component, particularly this public health program of the musculoskeletal disorders. ये methodology हमने जो क्या adopt किया है, एक national steering group हमने बनाया था from various experts in the country. Then there is an expert committee under the DGHS with the Director General of the DGHS with we have entrusted this task ultimately to formulate these things into the research council, respective research councils. The secretariat were made at the research council level for individual system of medicine. For example, Ayurveda, Central Council of Research in Ayurveda Sciences, they were given this task for making the initial draft. Then working group, they have made a working group from even from different states we have invited experts. Then after that what we have done there, we made a editorial board. Editorial board consists of modern medicine experts and Ayurveda experts, and finally they have made the editorial board review, and finally this publication came. So this is the standard format we have adopted. The name of the disease, case definition, introduction, then diagnostic criteria, clinical examination, supportive investigations, and supportive investigations. We often debated that what kind of supportive investigations, and because we know in public health facilities all the investigations may not be available and may not be required also. So based on that, whatever essential investigations required at the public health facility for that kind of facilities are alone mentioned in this one. Sometimes you can see that even higher imaging techniques वगैरह mention किया होगा, but that is limited, that is optional. If such a facility can have that kind of luxury, then you can refer to such cases, and if it is warrants specifically, then also it may be required. Then red flag sign, principle of management, preventive management, interventions. And we have also, for example, generally you may be knowing that Agni Karma, we know there are two things that we would like to conduct the training program further strengthen, that is Agni Karma and Marma. Generally, there is a saying that for Ayush system, Ayurveda, etc., the pain management is a challenge actually. The initial, particularly this kind of musculoskeletal disorders. So effectively we can integrate these two interventions in our clinical practice. But somehow the technical know-how for Agni Karma and Marma interventions in our country is limited to certain persons, even though some states, for example Kerala and other states, actually they have undertaken massive training programs for Marma and other things, but it is not widely available. So मुझे ये बताना है एक्चुअली आगे हमको ये भी करना पड़ेगा, ये दोनों स्पेसिफिक टेक्निक, बिकॉज दिस इज ए स्किल ट्रेनिंग, ये अभी ऐसा वाला ट्रेनिंग में वो सिखा नहीं सकते. तो इसके लिए व्हाट वी इंटेंड टू डू इन द फ्यूचर दैट स्पेसिफिक what do you call skill based training will be provided, hands-on training will be provided in the some regional educational institute, teaching hospitals, like that we will like to do it actually. But somehow we have included the Agnikarma protocol as developed by the NCISM, National Commission for Indian Institute of Medicine, that one protocol already they have proposed. The same protocol we have made as an annexer to this STG. Then preventive management and yoga will be integral to all this, whether it is Ayurveda STG, Unani STG, Homeopathy STG, and what you call Siddha STG, yoga will be integrated, so that you are supposed to integrate wherever you are doing the these musculoskeletal disorders. As per the feasibility, yoga should be integrated. Then these are the 6 disease conditions we are mentioning: osteoarthritis, rheumatoid arthritis, cervical spondylosis, lumbar spondylosis, fibromyalgia, and adhesive capsulitis. We have thought about many disease conditions, but then there was a suggestion that most popularly reported to the Ayush facilities, and another thing consideration was the most challenging to modern medicine, particularly this fibromyalgia, like that cases actually, because there is no relapses as far as the pain is concerned. There Ayurveda can do much better. Based on that, we have included these 6 disease conditions, and we will e-book format. अभी आपको जो hard copy दिया है, this is only limited number. Everybody, you cannot make this बार print. आज का जो printing का कोई ज़्यादा relevance नहीं है, so we will make it as an e-book format, and we will circulate to all the states. Widely you can circulate these guidelines to whenever you are undertaking this training program. So before going from this training program, kindly make a commitment that within next say 1 month or 3 months, we will undertake this subsequent training. Otherwise, this will be whatever you are gaining from today, this will be lost. So don't waste for much time actually. Next, say only you have to discuss with your director of Ayush department, yeah, principal and secretary in charge of your department, and say we want to conduct at these regions. Bigger state, for example, UP, yeah, Madhya Pradesh, yeah, Rajasthan, you may have not 4 or 5, it may 6 or 8 regions you have to select. Smaller states actually, you can say 2-3 regions, you can cover all the entire physicians of your particular region. Based on that, that training program can be completed. Then this is disseminated to, I mentioned all these things actually. Healthcare facility based on essential drug list. That is more or less we have adopted. In certain conditions we have deviated 1 or 2 which appears to be essential for the practice, that also we have included. So these are the beneficiaries: Ayush practitioners throughout the country, practitioners centers of emerging integrated healthcare like AIIMS, Ayush professionals at co-located Ayush healthcare researchers. So this is in facilitate the interdisciplinary learning and research, this much. So we can just discuss any doubts or clarifications or suggestions on how to go forward this training program, or if you have any queries further how to conduct this training program, you can have.
Better program, sir, but only thing we have to give some the workshops will be more useful for the benefit of the people, I think.
Training and workshop ka jo objectives may be little bit different actually. Workshop we can say, for example, as you told that Agnikarma and this Marma interventions, that is a separate workshop that we can adopt in the country. That is a separate thing. But a general standard treatment guideline ka structure, contour, and what are the procedures to be followed, for that purpose this kind of training will be more useful for you. Any other suggestions or
So one suggestion is that we are doing a lot of work in this musculoskeletal, but what happens where we lack is the technical presentation of this, because we are not into the research paper, technical writing. So if we give the data to the qualified people, they can put it into some good research paper.
Actually, ultimately, most of you are postgraduates. Most of you are postgraduates in Ayurveda. So, for the purpose of the research, actually, you can use your own patient data, provided it should have the robustness. Generally, for the purpose of simply writing something, that will not be a research actually. So, if you want to make it a serious business, you have to first of all constitute an IEC. For example, already our research council have an institutional ethics committee. So, based on that IEC, you have to formulate in the state, and with their concurrence, a research protocol have to be developed, and you can have the patients and inform the patient consent. But there are certain limitations in the public health facilities to conduct the research program. Notwithstanding that, actually you can have many of the research program you can conduct from there itself. Particularly if you are working in the teaching hospital, there is a more scope for that actually. So, we encourage also such wherever the research setting, particularly in the teaching hospital, under the extramural research and other things, actually you can submit to the Ministry of Ayush for that grant in aid also. In addition to that, there is no harm in simple documentation of these things, but it may not be for example, as a full-fledged research publication. If you want to come up with that, actually there should be some serious thought on that actually.
Sir, I have one suggestion, because musculoskeletal disorder program.
अभी आपने सर बोला कि जो हम यहाँ पर ट्रेनिंग प्रोग्राम ले रहे हैं तो उसको हम आपको 1-2 महीने में डिलीवर करें, तो सर इसके लिए आपकी तरफ से कोई स्टेट गवर्नमेंट को इंस्ट्रक्शन
that we will request National Ayush Mission Division to write a letter to the state governments to further dissipate this training program to the field level functionaries. Accordingly, you can share your trainee load, resource persons, etc. to the ministry for simply for the information purpose. But you can, if you request any other expert to be part of that your team, because we cannot spare many experts from the central government actually, but at least one expert, if you want to request to part for your training program, we can suggest to our either through Research Council, National Institute, like that, we can request them actually.
Sir, I have a suggestion. Sir, because we are also implementing this program, and it's a hierarchy of CHO.
switch on the mic.
So in musculoskeletal disorders program, there is a hierarchy of CHOs and MPWs. So one of the mainstay of this program is Abhyanga, which is available at the level of Ayushman Arogya Mandir also. So this is the one add-on practice. So why don't you think about giving a best practice, because Abhyanga, when it comes to Abhyanga, the benchmark of Abhyanga is Abhyanga techniques is Kerala. So why don't you develop a module on Abhyanga for training of MPWs especially, because most of the MPWs are they are not Ayurveda people. They do not have any basic training in
actually, I understand. Okay, actually, this is a job because we have to develop the class of therapist. Simply doing the Abhyanga, giving that MPW, that may not be desirable actually in the longer run. So ultimately, what is required is we have to develop a therapist, and many of the state governments have already therapist course actually, and there are institutes in Kerala also. For example, NARIP, National Ayurveda Research Institute in Panchakarma, then even the Punjabi Bagh, the Central Council of Research in Ayurvedic Sciences, they are also conducting such a training programs, 6 months, 3 months training program for the, for example, the persons for the as a therapist course actually. So these are the requirement for the future, because until and unless we have creating a very specific therapist for the field, then the entire exercise will be very limited actually. So as you told, अगर MPW को अगर upscale कर सकते हैं तो then that would be wonderful. And the skills sector sub council under this Ministry of I think skill development actually, there also this Panchakarma therapy courses are running. So state governments may like to more and more avail that available facilities.
Excuse me, sir. Dr. Radhika from Tamil Nadu. I would like to tell you that we have 2 schools for in diploma for therapists. It's a 2.5-year course in 2 places in Tamil Nadu, one in Chennai and one in Palayamkottai. So I would inform you all that
yes.
there are full complete training program
Okay.
for 2.5 years, and I don't think that MPW can be trained for Abhyangam. It will be ideal to only have trained persons or therapists.
Okay.
So that is my view.
Okay. So I think this training program, whatever the further other personal trainings and what is the requirement, that you can discuss in the tea time or lunch time. Mutually you can discuss, but actually because now we have to continue with this standard treatment guidelines sessions, I think we should focus on that. Okay. If no other points are there, then let's.
Excuse me, sir.
Ah.
So we're talking about the main importance of the training is cascading of the information passing on to whoever, at the ground level.
Yes.
So my question is, we here are not exactly representative from the DHS level.
Mm-hmm.
So I think if you're going to, if you're going to talk about, a proper budgeting, so as somebody has mentioned that, it should be a direction from the, from here, and also I think we all will be submitting a report what we have learned, but if that can be collaged, because when we budget again, there is always a problem, sir. So how do we overcome that budgeting? We will say कि पैसा ही नहीं है मेरे पास. So how do we overcome that
see,
challenge?
the decision has to not taken by you actually, because the state government and your director Ayush and director health services who are you are reporting to them actually. So they have to take a view, because for as far as the financial assistance is concerned, actually ministry has already provided under flexible components and many other things, actually funds have been provided. So they can take with the approval of the ministry, they can take for such a training program. We won't object. Generally that is what is happened actually.
So one more thing you mentioned about we specifically have for IEC materials. So how, if you could just give us a flow chart, how do we go about to even get those IEC materials, because that's one of the main challenge that we from Meghalaya face. Thank you.
Okay, many of the IEC materials are available. Research councils have already made the IEC material that we can ask them to share with the state government. There won't be much problem. And many of the state governments are taken enough funds for IEC aspect. So by this time, they should have developed many of the IEC materials, isn't it? Because in Meghalaya also they have taken the IEC funds. So
I'm sure they must have.
Yes.
For musculoskeletal disorders, the National Life Mission guidelines is provided that there will be a doctor who is taking care of these things, and not the CHOs will take care of these things. So,
I know, actually you have to understand that the
slightly different. Yeah, I will explain you.
Next session you will explain.
What we are getting is, sir, for all the programs, not only this musculoskeletal, but whatever the programs are mentioned in National Life Missions, we are getting the grants for IEC material and this and that, but we are not being provided any manpower and the staff for this. So the guidelines to the state government for utilizing the grant, which is for the manpower, which is essential. Why? Because we are doing all the things together, and it is little bit
that is what
hampering our clinics.
In next session, the details how we are supposed to go under that particular program of musculoskeletal will be explained. Okay. So if no other, because I have to rush to another meeting, that is why. So
actually
we will discuss in the evening also. There will be a concluding session at that time. Whatever you have learnt and everything has to be discussed. So before that, Dr. Ramodar, ये वो इनको circulate किया है वो pre training. Okay. That आप circulate कर लीजिए, आप fill up कर लीजिए, because we want to assess your current existing knowledge base, and after the training also we will be circulating another things actually, so that you can just make your response. Thank you all.